Disappointing news on Sunday night that the AstraZeneca vaccine, which arrived here last week, is not fully effective against the new variant of the coronavirus, the dominant variant in our country, which means we may not be able to properly use it. The Health Minister, Dr. William Kisa, confirmed the Johnson & Johnson vaccine, which does work against the new variant, will arrive in the country next week. It raises questions. How do you manage vaccines when a virus like COVID keeps mutating? Aisha Abdul Karim is a journalist at the Baker Cisa Centre for Health Journalism. Aisha, good afternoon to you. I mean, there must have been huge disappointment at this news around the AstraZeneca vaccine. It shows you how difficult the situation actually is.
Yes. So I think, as disappointing as this news is, it also, as with many things, even though it can be considered a failing in some circumstances because it showed very little efficacy of the AstraZeneca vaccine against the new variant that we have in South Africa, what it does show is it still gives us some kind of answer. It gives us an indication of what we need to be thinking about and where we should be looking. Up until now, we've really had very limited clinical data on how these vaccines are going to be performing against the new variant that we have circulating in the country. So the AstraZeneca results, along with the Novavax and Johnson & Johnson results, which were announced, over the past month, all help give us clues that point us in the direction of, we need to be rethinking how we're going to be rolling out vaccines in this country specifically because we have a unique challenge in our variant and we need to be figuring out how to adjust our strategy to address that problem.
I mean, this has all happened really fast. I mean, it's completely understandable from the point of view of the scientists who developed the vaccine. They were working with the first variant. Now this new variant came along, and the reason that this has happened is that it seems, I mean, I'm no expert, but it seems the virus mutated very quickly. And if it can mutate this quickly, this is going to make this a very big problem for a long time.
So, in terms of the coronavirus in general, why mutations weren't taken into consideration previously is because from what we had observed of the virus up until, the latter part of last year was that this particular version of the virus mutated really slowly. So it would have maybe 1 or 2 mutations per month. And they wouldn't be major mutations. They would be kind of small ones that didn't really impact what the virus was doing. Now, the problem with the variants that have been discovered is that they have a huge amount of variation. So they have about over 20 mutations within the virus itself. And some of these, like the previous mutations, are insignificant and don't really mean anything. And the issue with the variant that we have, the 501YV2 in South Africa, is that it has about 3 mutations that are really significant in terms of changing the structure of the virus and how it attaches to human cells, which is why what we saw during our second wave was, a much faster spread of the virus because of how it's changed. And that's why these variants are concerning. It's not just that it's a large number of mutations or that the virus is mutating, because that was expected. What makes it unusual and what makes it something that we have to be paying attention to is actually the location at which the mutations are occurring. And that is what's allowing it to firstly, attach itself easier to people, which allows it to spread faster, but also worryingly, it allows it to evade our antibody response, which is basically your body trying to fight off the infection, and whatever response you generated previously is not going to work as well against the new variant. So those are the 2 changes that really have kind of alerted us to these variants as something that we need to be keeping an eye on and really researching further in terms of what are the things we need to be changing in vaccines in regards to that.
I mean, the obvious fear is that the Johnson & Johnson vaccine, there'll be a mutation, then that won't work.
So I think with Johnson & Johnson, why it is one of the more promising vaccines is that not only did it have a higher efficacy against the variant that we currently have at 57% compared to the 10% of AstraZeneca and the 49% of Novavax, what actually makes Johnson & Johnson quite promising is that compared to all the other vaccines we have, it's a single dose vaccine. So it has very high efficacy in only 1 injection. So people don't need to come and get a second shot. And so what that indicates to us in terms of, practically vaccinating people, is that we can give people a second shot to supplement the initial immunization and protection that they've been given. So if it turns out that the virus keeps mutating and maybe the Johnson and Johnson vaccine is less effective against the variant that we have, we can give people what's called a booster shot, which is essentially a new vaccine that's designed specifically to target the variant, and that will help elevate the protection that someone is offered by that vaccine. And it can be done with the other vaccines as well, not just with Johnson and Johnson. It just is more promising with Johnson and Johnson because you have such high efficacy with only one dose already.
So, I mean, there are various things here. For government, on one level, I mean, if a government knows a vaccine works against a virus, well, that's easy. If government knows it doesn't work against a virus, that's easy. The problem really is the position we're in now. I suppose you'd call it an era of scientific uncertainty, right? We don't know how effective the AstraZeneca vaccine is against the virus. So now if you're government, what do you do? I mean, the clock is ticking on the expiry date. I realize the expiry date is actually a movable date for scientific reasons. There's nothing wrong with that. But I mean, government is now in a very tricky position.
Yeah, so I think this is a challenge that we face. And I just want to say, this is kind of the variant, what it means for us as a country is basically, in terms of research, we're once again put into the space where there's a lot that we don't know and a lot we need to figure out. And because the AstraZeneca vaccines are here already and we have 1 million doses, we kind of need to start answering these questions that we have as quickly as we can. And so, the key question that we're looking at is not just with AstraZeneca, but with any vaccine, is does this vaccine protect people from developing a severe case of COVID-19? And can it prevent hospitalization? Because what the purpose of the vaccine is basically to help reduce the burden on the healthcare system and offer protection to people from severe cases of COVID rather than mild cases. So the proposed idea at this point is because we don't know against the variant that we have if these vaccines can offer protection against severe disease or if they can reduce hospitalization. So what the government is proposing and what was outlined on Sunday evening is instead of doing a mass rollout like we had originally envisioned, is to rather try a sort of stepped approach in which the vaccines will undergo sort of like a pilot project where we're going to test them in a smaller group of people, which is going to be healthcare workers because those are the top priority and the most vulnerable to disease. And then we'll see if the vaccine can prevent severe disease and hospitalizations among healthcare workers in this sort of small scale trial. And if it shows that, for instance, AstraZeneca in the study can protect people from severe disease, then we know, okay, that's the green light. We can start looking at maybe rolling this out to a wider group of people. If, however, these kinds of studies show that these vaccines aren't providing the protection that we need against severe disease, then we need to stop rolling out those vaccines and we need to take them out of our plan completely. So this is one way in which we can try and get answers faster to the key questions that we need before we start going into mass rollout of any vaccine.
How important is it then for us to keep testing for new variants? Now, let me just sort of put some of the numbers in context. We know from the number of excess deaths during this time that not everyone who is dying as a result of COVID-19 and its associated impact on society is actually passing away after being tested for the disease. The number of excess deaths during the various waves has been so much higher than the number of confirmed cases in certain ways. So my question then is, if we aren't able, and let's be honest, we aren't able at 850 Rand a test, we aren't able to test everybody who shows a symptom of COVID-19, could there be new variants which are emerging which we are not actually able to catch in time?
So I think, when it comes to sequencing and identifying variants, I think it's really important to recognize the infrastructure that we have in South Africa. And, the CRISP team and the genomics team that was sequencing the virus last year was actually one of the first in the world to be able to identify a new variant. And that's because the system that we've had in place since the beginning of our outbreak is that we sequence our viruses. And so that's why, because we were doing routine sequencing and it's not a new thing that we've kind of thrown into the mix, we were able to identify the variant very fast. And it's highly likely that if new variants arise, we'll catch them in the same way. And in terms of, the numbers situation, it's really not about the number of tests that you're sequencing, because at that point when we identified the new variant, the 501YV2 variant, towards the end of October last year, we hadn't sequenced a large sample of viruses because we don't have the capacity to do like huge numbers like the UK, for instance. But within the amount that we are able to sequence, we are still able to detect these variants. And because the variants that are becoming dominant, which are variants that we're concerned with, such as the 501YV2, where it's spreading and really just moving very quickly and becoming dominant in the landscape, it doesn't matter how many people are getting tested overall and if we're missing tests, because when the variant starts to dominate, we'll catch it through the routine sequencing as we did last year.
Okay. And then, Aisha, I mean, this sounds like a silly question, but I think it's actually going to be really important. We need a name for this thing, right? Trust me, I'm a journalist. I mean, if you're going to use the scientific name and it's got numbers and letters, it's not going to catch on. We've got the Brits. I mean, how dare they? They can't even win a Rugby World Cup final. They're calling it the South African variant. Our response is to call it the Kent variant. I mean, the fact is that we actually need to give this a name. And I don't know how we go about doing this, but this is not going to be the last new variant we need. And the last thing we need to do is to call it the Trump variant or the Brazilian variant or wherever they come from. We need to move away from geography, right?
Yeah, so the World Health Organization basically put out a recommendation a few years ago saying that we shouldn't name viruses or variants of strains after the location in which they're identified, because it has obviously very stigmatizing connotations. So it's, the reason that we don't call the coronavirus the China virus, just because that was where it was first identified. And the same principle applies to the variant, in that we shouldn't be calling it a South African variant or a UK variant, or it's really not location based. It just happens to be the place at which it was identified. On the naming issue, I do recognize that the naming we currently have is not the easiest for people to pick up. 501YB2 doesn't really roll off the tongue, neither does E.1.1.1.7. So at the moment, the genomics teams that have identified the variants and other researchers are kind of working together with the World Health Organization to try and come up with a name that we can use, or like a naming system for the variants that will help provide people with an easier way to refer to these things. But until that point, unfortunately, we are stuck with using the scientific names that they've been assigned, which in our case is 501Y.V2.
Can't we just call it coronavirus 1, coronavirus 2, or 2.0 or something? Aisha Abdul Karim, thanks for the chat. Really do appreciate it.